All right, are we ready?
Great.
Okay. Welcome to In the Field, Voices from the Frontline, the podcast where we explore the heart of patient-centered care through authentic conversations with physicians who live it every single day. I'm your host, Matthew Francis, a pre-med student passionate about learning what it truly means to treat the patient and not just the disease. Today, I'm excited to be joined with Dr. Paul K. Herickhoff, an orthopedic surgeon and sports medicine physician at Penn State Health. Dr. Herickhoff specializes in hip preservation and arthroscopic surgery, with a clinical focus on helping athletes and active individuals recover from complex hip and groin conditions. Before joining Penn State, Dr. Herickhoff served as a medical officer in the United States Navy, experiences that continue to shape his perspective on teamwork, resilience, and patient-centered care. His his academic and research work has advanced understanding in hip arthroscopy, femoral acetabular impingement, and rehabilitation protocols that help athletes safely return to play. In addition to his clinical and research contributions, Dr. Herickhoff also serves as a team physician for Penn State Athletics, collaborating closely with coaches, trainers, and strength staff to optimize athletes' health and performance at the highest levels of collegiate sports. Dr. Herickhoff, welcome to the show.
Thank you for having me, Matthew.
Of course, no problem. So the first thing that I kind of want to get into is your background and journey. I always like to start these conversations off with understanding how you came to be where you are now. So the first question that I want to ask is, can you tell us a bit about your path into medicine? What drew you to orthopedics and sports medicine in particular?
Yeah, so I grew up in a small town in Minnesota, and we had just one primary care doctor in our town who pretty much did everything. And, he was a very respected member of our community and did a lot for the community. So I was fortunate that I was always healthy and didn't really expose myself to the rest of the medical field until I was an undergraduate when I did like a summer internship at our local hospital, and I was able to kind of explore different aspects of the medical field, surgery, anesthesia, in the clinic, primary care. And so that's when it really solidified for me, as an undergraduate, that this is what I wanted to do. And then in terms of orthopedics, I actually took a little break between undergraduate and medical school, and I taught high school in Baltimore City for a year. Kind of gave me a nice perspective being out of the classroom and another experience to help me relate with patients. Um, and then once I started medical school, I thought orthopedics might be something I was interested in, but I spent like a summer doing research with an orthopedic surgeon, spent time in the operating room, and then when it came time to sort of do my clinical rotations, I did orthopedic kind of at the beginning again, just to kind of be like, all right, I'm sure this is what I want to do. And then once I made that decision, I've been happy with it ever since. As a kid, I loved sports. Never was good enough to be a professional athlete, even though I told my mom I was gonna play football someday. And but I'm fortunate to be able to take care of athletes nowadays. It's really fun to see somebody you operated on be back out there with their teammates, playing the sport they love, um, and being on the sidelines. So I really enjoy that part of my job.
Yeah. I remember while I was chatting you, there was a young man who had a knee injury, and you were just kind of telling me the course of his route for recovery, and how it took so long and how he missed seasons coming back to the sport. Yeah, and you were kind of just helping him this entire way through his journey to recovery. And I thought that was a very fascinating thing to see, like how you were actually there through the entire time of his recovery and just cheering him on and helping him understand how this injury is not the end of it, but just a time where he needs to stay stagnant in this period and recover. So I thought that was interesting for sure.
Yeah. Yeah, it's a big deal when you have a surgical injury, like especially if it's your first one, right? If you make it to a Division I athlete, like being successful and being able to perform at a high level so it's devastating for a lot of kids. There's a lot of people crying and having being really sad, and but then when they overcome that initial grief phase and dedicate themselves to their rehab, it's like they're a whole different person a couple weeks later. So
For sure. It's an amazing thing to see. Speaking of You were speaking about medical school previously. I know you practiced as a medical officer in the U.S. Navy before transitioning into academia and clinical sports medicine. How did that experience shape your approach to care that you function in now?
Yeah, I mean, I didn't grow up in a military family, so I feel like it really, number one, there's a lot of veterans here in central Pennsylvania that I take care of. And so to sort of have that shared experience of being in the military, even though I wasn't like a frontline guy, but just, there's that sort of collegial nature to it. You understand some of the stuff that people have been through. You learn a little bit about the military health care system and some of the challenges that some of these patients experience before they kind of get to me now that I'm in the civilian world. But really great patients to take care of. People who have, you know, signed up to serve our country. There's really, no person I'd rather take care of than that. It's pretty amazing. But some of these guys, they have tough problems, and some of them have mental health issues and stuff that maybe I can't fix, but at least I can focus on their musculoskeletal issues and get them some quality life back.
For sure. I mean, during that time, what have been some pivotal moments or mentors in your career that have influenced the philosophy as a physician and a researcher? So at that time, were there any moments that have kind of shaped the way that you think? Any specific patient interactions that you can share with us, things of that nature?
Yeah, I mean, being in the military is it was kind of a shock to the system in a lot of ways because I was at a small hospital in South Carolina, and it was me and two other orthopedic doctors who were about my age, having just left like a huge medical institution, where we had probably 20 plus orthopedic attendings with a lot of gray hairs and just tons of experience. So when I started in the military, I really leaned on my mentors from my residency program, and I'm still thankful to this day for, all the help that they gave me, because it's quite a bit different when you're doing something for the first time, right? And you're the one that's responsible. And so just to be able to talk things through with somebody and have those mentorships is really critical. And now that I'm not one of the old guys yet, but I'm getting there. And having trained some younger surgeons, I enjoy that role and being able to give back to people who are, in the shoes I was in, 12, 15 years ago, just starting off.
It's an amazing experience becoming from being a student to being a teacher. It definitely is a wide jump.
Yeah, yeah, it really is. Every day is really a school day still, though. I'm blessed that I still feel young. I don't feel like I'm one of the old guys yet, but there's always something new to learn and pass on to the next generation.
Sure. Speaking of the clinical and research interests, I know your research includes the focus on hip arthroscopy and conditions like femoral acetabular impingement. Could you kind of describe those things for us? For the listeners that don't really know what that is, how would you describe these things to someone who has no knowledge or information on the topics?
Yeah, so femoral acetabular impingement is kind of a bucket term for hip pain, and the technical definition is impingement between the top of the thigh bone, called your femur, and the hip socket, called your acetabulum. And a lot of the research that kind of developed in this area came out of Switzerland within the last really 20 plus years. So before that, not many people were getting treated for hip conditions unless they were bad arthritis and needed a hip replacement. And so um, I think the field is kind of evolving to recognizing that it's not just about bony problems. When you're an orthopedic doctor, the first thing that usually happens when you go to the office, you get an X-ray, and certainly some people do have bony abnormalities, but there's also some people who it's a soft tissue issue, and the issue is with their labrum, which is kind of like this ring of fibrocartilage that goes around the socket. And some patients, especially like young females, will see that they have some micro instability where the ball is moving around inside of the socket more than it should. And that can predispose them to getting labrum tears and other kinds of hip pain. So femoroacetabular impingement, I think, is interesting because number one, it's kind of new and we're still discovering new things about it. I think number two, I think it's interesting because you know what we're doing now is not what we did 10 or 15 years ago, and then it's also technically it's very challenging. So the hip joint is covered by thick layers of muscle around the hip, and so it takes a while to sort of be comfortable with doing that surgery. But for the properly selected surgical patients, some of my patients, from more rural areas in northern Pennsylvania and things like they've had problems for a year or 2 years and no one's really been able to figure it out. So when they come see me and I'm able to treat them and have a successful outcome, it's really rewarding.
Mhm. Yeah, that's amazing. I know you said that around the hip joint, there's a lot of muscles, right? There's a thick layer of muscles. So how does that process even look to rectify some of these issues with femoral acetabular um, impingement?
Yeah, so when we do the surgery, we apply traction to the leg. And so usually the patient's paralyzed so that we're not fighting against those muscles. And we have to open up the ball and socket joint so we can work in there. The capsule of the hip joint is also really thick because the ligaments are basically capsular thickening. So your mobility is limited when you're going through a thicker soft tissue envelope, and so you have to kind of release a little bit of the capsule, and your portals have to be really in the right spot. And we use fluoroscopy, like a intraoperative X-ray machine that helps us to do the surgery. Um, and so, but it's a team effort. I got to have the anesthesiologist on my side, making sure that patients relaxed so I can do my job and their blood pressure's under control so I don't get into a lot of bleeding and things like that.
It's a very delicate, important process, as well as for hip arthroscopy. How does that? How could you explain that as well? Hip arthroscopy.
So arthroscopy just means putting a camera inside of the joint. So as opposed to open surgery where, a patient gets a long incision, higher risk of complications like infections or scarring, more pain afterwards, longer recovery. So minimally invasive surgery is kind of what arthroscopy is. And, there's a big demand for that for patients and, you know, reasonably so because it does have a lot of advantages. It's technically, it takes some while to master that procedure, but once you've got it figured out, it's the open surgery, starting like 15, 20 years ago, a lot of that's gone away because so many things can be done arthroscopically now that previously patients needed a big incision.
Yeah, I know you were showing me actual images while I was shadowing. I know you said it takes a while to become a master. How was it first starting off using that device?
Yeah, and I mean, I don't know if I would say I'm a master now, but definitely, like I said, every day is a school day, and you get better throughout the years. When I started off in residency and got interested in it, there was one sports medicine surgeon that would, do a handful of cases a year. Um, and so, you know, try to get more exposure to it. I called down to the cadaver lab and we were able to get a cadaver and do like an after hours session up in this operating room. And this attending who's been one of my mentors, Dr. Ned Amendola, who's now at Duke University. He's actually the president of the American Academy of Orthopedic Surgeons this year. Um, he was great and kind of piquing my interest in that. And, he and I have stayed in touch over my career. And then I went from residency into the military, and I started seeing these patients with hip issues, couldn't do their active duty, to the point where like they were like, either I have surgery or else I, need to medically separate from the military. And so I started to go into some courses, some of which were sponsored by industry. So I kind of learned from other people around the area. And so I feel like I kind of started off in the military, doing a few cases, never felt like I was like a master or anything at that time point. So when I went back to do my fellowship, I really wanted to be at a place where I could hone my skills in hip arthroscopy. So I ended up going to Stanford, where Mark Safran was one of my mentors there. He's still there, and he's one of the thought leaders and president of so many hip arthroscopy associations. So I just learned a ton from him and just really opened up my eyes to things I hadn't thought about before. So it's been a process learning to do hip arthroscopy, and I have done some research projects in it again because I find it fascinating how there's still some things that we don't have figured out, and it's going to continue to evolve through the rest of my career, I'm sure.
Yeah. It's a very amazing thing. I know me and you were talking about hip replacements while I was there, while we were shadowing. In your view, what's the most exciting or promising advances in hip preservation surgery over the past 5 to 10 years? So I know we were talking about like the functionality and the method and how now we're trying to replace the hip. Like, what do you think now is the best kind of methods of preservation for the hip now in the past 5 to 10 years? How do you think that looks now?
Yeah, I mean, I think for me, the most exciting thing about it is a lot of what I learned from Dr. Safran at Stanford, this concept of micro instability, because a lot of these patients, if you look at their x-rays, they kind of look like a normal x-ray. There's not a lot of evidence of any bony impingement. Um, the MRI, like a lot of times the labrum, it will be unstable when we get to the time at surgery, but actually on the MRI, it doesn't show that the labrum is torn. And it's hard to talk to patients about like, hey, like you'd be a candidate for surgery even though your MRI says you're normal, but they'll have physical exam findings that'll strongly suggest that they have, a tear in their labrum, or they have a response to an intra-articular injection where they get pain relief in their hips. So we know that something's wrong in there. But it takes a little bit of a leap of faith on the patient's start to be like, okay, I'm going to let this dude, put a camera in my hip and try to fix something that, the MRI is saying is normal. But so anyways, and I've had great luck with those patients. A lot of young females I've operated on have done really well. And so I think that's an area that we're going to continue to see is more research in hip arthroscopy in the future, and hopefully have a better understanding of how we can diagnose this better. Like, is there different MRI techniques or things so we can kind of give the patient a little bit more reassurance before undergoing surgery.
Yeah, it's a very complicated thing, especially with these collegiate athletes. My next question would be, what are some of the common injuries or patterns you see with these collegiate athletes, and how would you say to approach prevention strategies for these injuries?
Yeah, so we see a lot of sprains, ankle sprains. I take care of Penn State's basketball team. That's probably the most common injury in basketball. But when it comes to like surgically treated injuries, ACL tears, meniscus tears, and then shoulder, probably more commonly injured joints, a lot of labrum tears in the shoulder we'll see in our young athletes. And so when it comes to preventative treatments, a lot of that relies on the athletic training staff and the strength and conditioning coaches. We have some really great technology nowadays with like Catapult, these sensors that they wear during practices, and so you can kind of monitor their load and stuff, and ramp people up appropriately, like sort of preseason, and then how to like balance like during the season to keep people healthy. So I think that's been a benefit for just to have like the same language that we can talk about, that's something objective, right? When you have those catapult data or other kind of sensors to monitor their activity, because a lot of the stuff we see, overuse injuries, those are the kind of things that you can prevent. You can't always prevent, somebody gets tackled by somebody and has a bad fall. That's going to happen. But if it's an overuse injury, that's something we could potentially, treat or prevent. I lost my volume here on you, Matt. I can't hear you. Sorry.
Sorry. Um, uh,
There you go.
there we go. Okay. I was saying you're a team physician for a high level athletics division, Penn State. What are some unique responsibilities and pressures that come along with that role, and how do you manage them?
Yeah, I mean, there certainly are some pressures. I try to separate myself as much as possible from that and just treat my athletes like any other patient. Um, Obviously we all have read about, NIL and athletes being paid and, especially at a place like Penn State, kind of a almost a semi-professional or professional sports kind of environment. But, you know, despite the fact that these guys are on TV and stuff, they're human beings like you and I at the end of the day, and they just want to be able to participate in their sport and be healthy, not just for the next year or season, but when they're done playing sports and have kids of their own and families and things. Um, so anyways, yes, there's some pressures, and yes, they get a little bit special treatment. There's a timeliness to their treatment where, stuff gets done faster. We have a great team in my office, my nurses, my PAs, our surgery schedulers, our office staff. We've got a lot of people in this office that um, help out in ways that are sometimes not seen by, the rest. And, we get the credit as doctors or whatever, but really it's a team effort to take care of, these athletes and the coaching staff and everybody else, to make it a success. But it's rewarding at the end, again, seeing these, guys out there playing, their sport of choice, is really special. Fortunate to do that.
Yeah, I know you kind of spoke about the collaboration in the outpatient setting, um, but how does that coordination work with coaching, training, strength and conditioning staff to optimize the health and performance of these athletes? I know you spoke about the relationship in the outpatient setting, but how does that relate to outside of that setting with the staff that helps with the athletes?
Yeah, that's a great question. It does require a lot of coordination because there's a lot of people involved, and people have different specialties. So, the athletics department has, strength and conditioning. Obviously, I'm not a strength and conditioning coach. Do I like to work out? Sure, but I'm not like those dudes. There's nutrition people who really can help out. Our athletic training staff. So some of the ways we've tried to link everybody together is really been headed by Jonathan Salazar here at Penn State. We kind of in the last couple of years sort of came up with like a injury recovery kind of plan for the common injuries that we see, whether that's sprains or non-surgical injuries versus surgical injuries. And so I think it's important that you have kind of a framework that everyone can kind of reference off of. Um, that's the starting point. I think, beyond that though, like just having really good communication is critical. And our athletic trainers do a lot of that sort of go between, the physicians and the coaches. So everyone's on the same page. And so there's emails that are sent out about, this is our sort of how everybody's doing. So it's kind of out there and people can talk about it. There's no substitute for keeping the communication and making sure that everyone's sort of tracking the same thing.
Yeah, it's I don't know how you do it. It's a very complex system. And of course, you don't know everything, and that person doesn't know everything. And you're kind of collaborating a bunch of different ideas, specialties, and strengths just to help this athlete holistically. Um, so yeah, props to you for doing that, being a part of that. It's a very important thing. I know there's HIPAA and things like that, but can you share a case or an example where you had to make a tough decision, push for an aggressive treatment versus hold back for caution, for some of these athletes with some of the games they had and some of the things they had approaching? Can you kind of give us an example of how that would look?
Yeah, I think for me, the number one priority, and I think for any team physician is safety, right? And um, I've had patients before who have an injury that, might be a candidate for surgery. But it's happening in preseason and the season's about to start. So if we did the surgery, they would miss the whole season, or it's, their senior year. They don't have any redshirt time left. They're planning on graduating. So, I had, several athletes like that. One of my patients dislocated his shoulder, before season started, and we had a conversation. I said, if you play this year, you're putting yourself at risk for causing more damage to your shoulder. But you know, by the same token, it's, I view my role as an educator too. So I need to educate the patient about, what are the risks, what are their options, and then, it's still patients are autonomous decision makers. They get to make the call. I don't view myself as, paternalistic and I'm telling you what you have to have. I just like to lay it out there. And this one patient, it was his senior year and he played and his shoulder popped out more than once during the season and but he kept playing and then the week after the season was over, he had surgery and I fixed it and his tear was definitely worse than it was beforehand. But he had a good recovery and I we've stayed in touch over the years and I don't think he would have changed his decision looking back at it. But everyone's different. The next person I see that might be in the same situation might choose to have surgery and miss some time. It's just people come to the medical field with their own kind of sets of experiences and symptoms, and so every patient's different.
In that specific situation, do you think that that wait was worth it in his case, or do you think that he should have gotten it done earlier, or is it more so just up to his discretion?
I mean, I think if I, what you don't want to do is expose somebody to the risks of surgery and then rush them back, right? Because they're missing time, and then they re-injure themselves, and then you have to do another surgery, right? So, so I'm very like straightforward about with my patients about how much time they're going to miss. I try not to um, promise them anything that's unrealistic, right? Like if you're going to have a surgery, like, we're going to do it the right way. You're going to rehab the right way. We're not going to put you at risk to go back out there. So, you asked earlier about like rehab protocols and stuff. And so like we do like functional testing, right? Like before an athlete goes back. So it's not just somebody's not just telling me, look, doc, I don't have any pain. I'm ready to go back. It's like that's great, but you also need to prove it like on some of these tests that you are safe. So in this particular patient, I mean, if we had done the surgery, like he would have missed like the majority of the season. It's a 6 month recovery after shoulder surgery for the vast majority of patients, and that's what it was for him. After that season, and he actually ended up getting like a COVID year to come back and play the next year, and did perfectly fine the next year. Didn't have any issues. So I think it was the right call. Again, if the patient's happy, I'm happy. And, I don't, yes, it was a little bit more work for me to do the surgery, but he didn't have any like damage that like wasn't fixable. If I had a patient that I thought was like, you're going to cause irreparable damage, then in those patients, like, it's a different conversation.
Speaking of patients and the field of orthopedics and sports medicine, do you think there are any gaps or unmet needs for some of these patients, either scientifically, clinically, or in the infrastructure as a whole? Do you think there's any gaps or unmet needs? Totally, yeah.
Yeah, I mean, I'm not a mental health person. I think there's a lot of pressure on athletes, like more so now than ever. And because I just feel like, it used to be like, if you're a pro athlete, like the pressure was on you. And then now it's like, we're seeing it more pressure in our collegiate athlete. Even the high school, kids I take care of, we're seeing a lot of overuse injuries and, young kids are starting off, they're playing a sport, all year round, which we know is bad, that you're at higher risk for overuse injuries. But, um, a lot of times, like, they feel like, or their parents feel like if they want to make this travel team, then they got to be doing this year round. So, you hate to see that, like, take the fun out of it. Sports are supposed to be fun, right? You're supposed to get long lasting like relationships from that. Like learn to be as part of a team. And so, I think the mental health thing is important. I think maintaining perspective is important. It's not something that certainly an expert at, but I think about a lot and try to sort of see if there's anything underlying, that could make a patient's treatment more challenging because like I never had that kind of stress. I went to a small school where I was fortunate I could play, even if I was no good. I was still on the team, but it's different with nowadays than it was when I grew up for sure.
Speaking of these athletes, I know you're talking about different methods used for helping them recover. Do you see these technologies like imaging, biomaterials, wearable sensors, or AI influencing orthopedic care in the next decade? Do you see these things pushing forward the field, or are they kind of just the standard quote, the standard now?
I think it's going to continue to evolve. I think we're in the era of big data. I think AI is already there in a lot of medicine. Patients are Googling their conditions and coming with good questions about things. There's some information that's out there on the web that's inaccurate, and that can be a challenge to sort of dispel some rumors. I think Mother Nature hasn't changed. Like the human species has, roughly been the same genetically for the last, 100,000 years or whatever. So there's some things about like, soft tissue healing and bone healing is what it is. And, you can attach 18 million different kinds of devices to them or different, modalities and things. But you can't speed up Mother Nature. And I think that's always important to keep in the back of your mind. To me, the conversation always starts there. And we know a lot of that from animal studies about, how long does something take to heal. So I'm always open to what's the latest and greatest, that I certainly don't think I have all the answers to what might help for recovery, but there is a limit to all of these things. And, we I think one of the challenges with the modern media is, you always hear the success stories, the NFL player who's back, 3 weeks after surgery or 2 weeks after surgery or whatever, but it's not so common that you hear about the failures, the person who didn't make it back and uh or the person who maybe they put him back out there too soon and that was a mistake. So just trying to set appropriate expectations from the outset, I think is really important when you're managing any patient, but especially with like high level athletes.
Yeah. And speaking of research in this sense and new technologies, I know research, there's always often a gap between research translating into clinical practice. Um, where have you found effective in bridging that gap between learning about things, bringing research into your clinical practice? How have you kind of bridged that gap? Have you brought things that you researched into clinical practice yet? How do you see that?
Yeah, I think it really comes down to trust. Like if you ask just a person off the street about research, like it kind of sounds like experimental, right? Like nobody wants to be the guinea pig, and certain populations, especially, when I was in South Carolina in the military, some of my African American patients, they had a healthy suspicion of the medical field for legitimate reasons. There's bad historical examples of Tuskegee and other things. Where patients have not been treated the way they should have been. Um, and so if you're gonna apply research to clinical practice, number one, you got to make sure the research is solid, right? Like, if there's a study that had like 5 patients in it or something, like, that's not good enough to like, do to everybody. But if you have good research, then it's about trust and communication, like, hey, like this is something that we think can help you. And I think it's about if you're introducing something new, also monitoring that, right? Like you can't just like say we're going to do something new and then if it doesn't work out, like, oh, we didn't know, like, you're responsible for that. Um, but there is a divide there that's really important because there's no reason we should be, as a society, like devoting all these resources to research if they're not going to actually help patients in the long run. Like for instance, when I was in the military, we were taking care of Marines, and I saw a lot of stress fractures. Like people are showing up at Paris Island to do their basic training, and they're working harder than they ever have, and they're getting stress fractures. And so I started checking their vitamin D levels, and turns out that like almost without exception, everyone's low on vitamin D. Well, I did some research and they had done like a level one randomized controlled trial, which is like the highest level of research with like Navy cadets. Okay. And yeah, the Navy's different from the Marines, but they're still like going through basic training where they giving them calcium and vitamin D and they reduce like the risk of stress fractures by like 20%. So I brought that study to the medical officers and people within Paris Island. And, it still was a challenge sort of breaking into that, like, hey, like here, we're going to give you like a candy bar that has calcium and vitamin D in it. And it's like, oh, like, what are they trying to do to us kind of thing. Um, so you have to be smart about it. You have to have the trust of your patients. You have to have good research to support it. But if you have all of those things, you can take research that's already been done and improve your patient's, treatment without necessarily having to start from scratch, right? If the research has already been done, you might just need to apply it.
Yeah, and that's the best method of actually doing it, where you don't have to really do much work. You just have to show and prove the work. But with that, I know you talked about how you're deciding if the technique or the study is ready to be adopted into your practice. But how do you stay current on the literature that you're seeing and the different research that's coming out? How do you stay current?
Yeah, so there's tons of journals out there. I try to stay up to date with reading sports medicine journals and general orthopedic journals. There's different Doximity and some other sort of medical websites that I subscribe to that, will send me like a curated list of articles and I'll read through that. And if it's something I'm interested in, I'll click on it. So I try to do that. And then beyond that, it's for me like an individual patient thing. So, even though I've been in practice for over 12 years now, I still see stuff that's like, man, that's weird. I don't know if I've ever seen a patient like that before. And so sometimes you gotta, you know, go onto PubMed and see who else has treated a patient like that. To sort of learn about individual patients. So for me, that's kind of how I stay current on things. Going to meetings is a great way to sort of stay up to date. That's required. You have to get, continuing medical education requirements to keep your state licensure. But all of those things, I think, help you stay current and up to date.
It's a great way to stay current for sure. Speaking of advice or philosophy to the people who are coming up, the people who you're kind of a mentor to, for young physicians or trainees interested in sports medicine and orthopedics, what advice would you give them via research, training, work-life balance? What advice would you give them?
Um, well, I would say that it's a very rewarding field to be in. I think, like I mentioned earlier, there are some special pressures to taking care of, high level athletes. So, you can't have thin skin about those kind of things. I think you need to be in a supportive environment where you're not trying to do it all by yourself. You got to have the appropriate, you know, structure in place with your office staff and infrastructure to support you. Um, but yeah, it's a really fun, exciting area to be in. People love sports. Athletes are fun patients to take care of. Uh, it's a long haul to get through medical school and stuff. You don't have to help by being a doctor. You could be an athletic trainer, you could be a physical therapist, you could be a strength and conditioning coach, a nutritionist. So there's more than one way to be involved with taking care of athletes. You don't have to just go hammer it away at medical school for a number of years like I did.
It's not an easy journey. It's not an easy journey, but it's a worthwhile one for sure. With your position now as a surgeon, how do you manage burnout, stress, the demands of being both a clinician and a researcher? How do you manage that?
Um, so, I try to have protected time, like so that I can be able to do research and you know, take care of myself, to do my own, medical appointments. They say doctors are the worst patients, so that's probably true. But you got to take care of yourself first. You got to take care of your family. Um, I think a lot of employers have tried to, have a increased focus on wellness and things like that. It's something that people can talk about nowadays that certainly when I was in residency, like nobody really talked about burnout. I felt like when I was a first year resident, that I was burned out at times and didn't really know how to handle that. So I think it's good that people are talking about it. I still think it's a real thing. Um, you know, the the demands of being a physician are real. The as the older I get, the harder it gets to get a phone call at 2 in the morning and, wake up and try to get my brain working to solve whatever issue it is, if I'm on call. So, I think talking about it, being realistic about it, asking for help when you need it, having good partners that can have your back, and giving you a hand if you need it. All these things help to prevent it, but it's important, like you're not going to be a good doctor for your patients if you're not feeling good about yourself,
Yeah,
or as good of a doctor, I should say.
yourself comes first, and then you can help other people. When it's the opposite, you lose one or the other. So for sure, I definitely do get that. I kind of want to zero back in, just look a little bit from a macro perspective at your perspective on athletes, right? As of now, you've gained all this experience and all this understanding on what an athlete actually is. And I want to see in your view, what does the optimal athlete health look like beyond just the absence of injury?
I mean, if I had to dumb it down to one thing, I would say it's people smiling, like we said earlier, like sports are supposed to be fun, and if you can smile, even, regardless if you have a winning season, losing season, like you can kind of get the vibe when you're in the locker room or at practice, uh, that, that's a reflection to me that, the patient's in a good place. And hopefully the whole team is smiling. Hopefully everybody's kind of supporting each other. I think that's typically the case. But again, I think because of, like we talked about, all the stress that is put on athletes nowadays, pressures to perform, concerns about financial remuneration and compensation, and is this my only shot at a career? Um, to me, like just having that perspective, because all these guys and men and women are, very gifted and very driven, and it's not like, you sort of get this message, right, that whoever works the hardest is going to be successful, and there's no question that hard work is important, uh, but you can't just work your way. You can work yourself to death and still not get the outcome that you wanted to. So I think, having resources in place that people can, um, if they need to talk to somebody, or if they need counseling or medication, whatever it might be, so that they're out there and they're smiling, then I think we've accomplished our goal.
Definitely for sure. That sounds like a very good method because, of course, you can be a wonderful athlete, but if your mental isn't good, if your mindset isn't on straight, if your mental health isn't good, that kind of starts deteriorating everything else. So that smile thing is a very critical thing to have. Um,
Yeah, watch Steph Curry next time he drains like 14 threes. He's smiling from ear to ear, right? You know?
he definitely is. For sure.
Yeah,
That
yeah,
was a great example.
yeah.
But in saying that, kind of getting off into the end note, with your career, what has surprised you the most? Whether that be in your research, in your patients, in yourself. What do you think has surprised you the most?
Yeah, I think the biggest surprise is just how fast it's going. Like I can't believe, I'll see patients that I operated on, when I first started here, and it's been like, 8 years that I've been here, and it's like, wow, that seems like it was just yesterday, and or you know, kids who were like high school students when I operated on them. Now they made it through college and they're out working, and some of them are trying to go to medical school and all these things. So earlier I mentioned about, my mentors, like, a lot of the guys I trained with, they're now like either retired or getting ready to retire. And, it's like, now I'm like supposed to be the adult in the room here, right? Like trying to teach the next generation. And so it goes by fast, and just trying to have that mindfulness of, trying to stay present, um, t take each day one day at a time, focus on making patients better, being a good father, a good husband, good community member. I think as long as I stick to that, you know, it's gonna keep going by fast.
Yeah, time, but definitely for sure. Speaking of time and mentioning the how time passes so fast, the final question I want to ask you is, what are you most excited about your work or in your research going forward in the future? What are you excited about? What's coming up?
Yeah, in the last couple years, I've started developed a collaboration with Dr. Spencer Skesney, who's like a tendon researcher at Penn State, and kind of trying to bridge that divide, like we talked about earlier, between like sort of clinical bench research and the clinical practice. He specializes in tendons, and one of the things we don't really understand now is tendinopathy. Like, you know, we've seen a rash of Achilles tendon injuries in NFL athletes and basketball players. Kevin Durant, Jason Tatum, Kirk Cousins. List goes on and on. And for a lot of these patients, they were completely asymptomatic before they had their rupture, and so so we're trying to learn more about why people get tendinopathy. We've got some animal models that, are showing that there's some different genes that are turned on in a hypoxic environment, meaning that where there's low oxygen tension, which is a lot of the areas where people have tendon problems, where there's a low oxygen environment. And so now we've started a clinical study where I'm actually taking human tissue. I do this surgery called a biceps tenodesis. A lot of people do it, but the tendon that we typically discard as medical waste during the procedure, we're now saving that tendon and looking at it in the lab to see, what genes are getting turned on in patients. And we're still in our very early stages, so I don't have anything breakthrough yet, and it'll probably be a while, but just kind of fun to feel like you're contributing to something that's sort of unknown, and you might be able to uh, move medicine forward a little bit in that area at least.
For sure. And good luck in your research. I know research is a very trying and patient thing, especially failing sometimes and then retrying, trying to figure out the method, trying to figure out what you can change to get to the goal. So I know it's a trying thing, but good luck in your research for sure.
Thank you.
Um,
Appreciate that.
of course, yeah. Now I just want to say thank you. We've kind of concluded our conversation here. I want to say thank you for this and for your perspective. I know your time isn't always very free and open, so I do thank you for making the time for me here to give your perspective on these different questions and these different topics that I know me and a lot of the listeners will probably want to hear your perspective too. So thank you for that. I do appreciate it.
You're welcome. Happy to do it, Matthew.
Thank you so much.